So the first step that the objectives of this lecture that are going to see how to interpret the intracardiac EGMs, where we do put our catheters and correlate the catheter position to the electrical signal. We will just try to see how we measure the baseline intervals in the basic EP study and other protocols that we are going to do, like pacing and extra stimulus and so on. This picture shows us what is meant by a unipolar EGM and a bipolar EGM. All of our catheters, they have multiple poles. We can have 4 poles. This is the minimum, a quadripolar catheter. We can have a decapolar catheter with 10 electrodes. We can have 20 electrodes, okay, and so on. What's the significance or the importance of the electrode? It does read electrical activity. So if I have a single or a unipole, just a single electrode, and I am going to see the direction of the signal from the tissue to this electrode, okay? Same as the ECG, same as the precordial leads in the ECG. They are unipolar leads, okay? If I am going towards this electrode, the signal would be a positive signal. If I am going away from this electrode, the signal would be a negative signal. And we could have a mix and match from this: a small r, a big S, a big R, a small s, a totally deep Q wave or S wave, totally positive wave, such as the ECG. So whenever I am putting my signal on a specific spot, this measures the direction of the electricity from where I am pointing. Okay? The significance of this in cases of ablation, if I am standing on the point of the origin of whatever tachycardia that I am ablating, the unipolar would go away from the electrode and it will be totally negative signal, just like this one on the left. This applies to focal origins of tachycardia, such as focal atrial tachycardia or a PVC ablation. But in our regular uh, studies, we do use the bipolar mapping techniques. The bipolar mapping techniques, they measure the difference between 2 poles or 2 electrodes on the same catheter, like 1 and 2, 3 and 4, 5 and 6, and so on. So it has nothing to do with the direction of the electricity. It does care about the amplitude of the signal rather than the direction of the signal. Do you follow until now? If anybody has any questions at any point, please stop me to ask about it. Is it clear until now?
I
The
have a
negative.
question.
Okay.
Sure, Dr. Joanne.
Yes. So you say that in the, like, for example, in the quadripolar, you don't know, like, you can't tell where is the negative and the positive. I am not getting
No,
that. Yes.
I mean, if you look at this signal, we have an initial negative deflection and
Mm-hmm.
then a positive deflection,
Yes.
right?
Yes.
This doesn't mean that the signal is going away or towards the electrode. It just shows the difference of 2 signals seen by electrode number 1 and electrode number 2, for example. And it does care about the proximity of the electrode to the tissue. So if I am standing near the atrial signal, okay, it will be a big signal. If I am standing away from the myocardial atrial tissue, it will be a small signal. It does not mean I am close to a focus or away from a focus in direction of electricity. I am just next to the conduction or away from the conduction. So I don't care about the positivity or negativity. That's what I mean. I care about the sharpness and the amplitude of the signal. Okay.
Thank you. Thank you.
Dr. Ahmed was about to ask something.
nowadays in our study we use bipolar, not
We use
unipolar.
bipolar.
Is
Yes,
it?
we use bipolar in our regular studies, except if we are mapping for a focal atrial or focal BVC. It helps us a little bit, the unipolar catheter, to make sure that we are standing on the focal point of the tachycardia origin.
What
Okay?
it mean if the tachycardia origin is positive deflection? If the tachycardia or the BVC have a positive deflection, what does that mean? I am close to the signal
لا, I'm away
when
from
you
the
use
signal. لو it is
unipolar.
positive, it has to be totally negative. I am standing on the origin so that electricity is going away from me. I am anywhere else, the electricity is coming towards me. Okay?
Okay.
I
Yes.
did send you the Joshua Cooper video before. You can both revise the Joshua Cooper basic EGM. It's one of the
Yes.
perfect videos to start with in electrophysiology.
Yeah, I will. Yeah.
Okay, so unipolar shows us if I am distant or close to the origin of a tachycardia. Okay, but it has nothing to do with the timing. We don't care. You don't care about this. تمام مش مهم. طيب, what's important بقى that we need at least 3 casters to be placed inside the heart. At least 3 casters. The regular are 4 casters. Okay? Why do we need 4? We need 3 because we need an atrial representation of the signal, which is probably in the high right atrium at the site of the SA node. We need another one at the site of the AV node or the His bundle, where there is an AV junction at the His bundle. We need coronary sinus to map the mitral annulus and the left side of the heart, starting from the septum, the posteroceptal region, the back of the left atrium until the lateral mitral annulus, if we could put the coronary sinus in the right place, and a ventricular signal. So if we did put the 4 signals, the 4 casters, we will have atrial representation, okay, AV area representation either at the AV node and His, and left atrial AV representation, and then purely ventricular conduction. I can measure.
Sorry, Dr. Rana, can we base the RV from the coronary sinus?
Sometimes the coronary sinus spacing captures the ventricle, but this depends on it depends on the patient, and depends on the output, and depends on the surface ECG to know which is captured, the ventricle or the atrium. But we do pace the CS in order to pace the atrium. يعني the regular
for
is
the
that the atrium is the one. Yes, this is the regular. But sometimes whenever you are pacing from the CS, you find that the patient, especially if you are in a branch, if you are in the middle cardiac vein or in a downward placed branch, sometimes you can pace the ventricle from the coronary sinus. So that's why we usually pace at 9 and 10, the most proximal electrodes, in order to be atrial, to have atrial capture. But if we are pacing from a branch, most probably you can capture the ventricle, and you know that you are capturing the ventricle from the ECG and of course from the intracardiac signal.
Yes.
Right? Okay. طيب. Those are the flow reviews that we need to know. And most of the cases that we do, we don't have this much casters inside the patient. We only have 3 in most of the cases, but this is the classic, and that's what we need to learn. If anybody is going for an exam, the 4 casters would be in place. And we could add also an ablation caster afterwards. Type. This is what you asked about Dr. Ahmed before. What do I see in the fluoroscopic views? Okay, what do I see in the fluoroscopic views? So let's draw a little bit on this image. Okay, so now this is what is known as, let's start with the RAO. It's easier. Okay, the RAO is a long axis of the heart. So I am cutting the heart in a longitudinal view. The anterior portion of the vertebral column marks the wall of the atrium. Okay, and then I do have the atrium right here until the His. Where is the His? At the AV junction. Okay? Slightly ventricular, but at the AV junction. And then this is supposed to be the tricuspid annulus. What about posterior? This is the CS castor, right? The CS castor is posterior and going inside the CS to the left side of the heart. What we need to know is that I will just correct a little thing. We just need to know that the RAO does not see right and left. The RAO sees atrium and ventricle. Okay? The RAO sees atrium and ventricle only. If we can see this is the RAO view. What are we seeing right here? If you can see my pointer. Okay. So the first thing, I have the vertebral column. Yes, I do have the vertebral column right here. And that's how I know this view is the RAO view. If I am not sure, I know that this vertebral column is on this side of the image, on the left side of the image. So this is right anterior oblique. The vertebral column would mark the wall of the right atrium. The coronary sinus would mark the posterior area just above the tricuspid annulus. The His would mark the anterior portion of the septum, okay? And down here is the right ventricle. And up here, and very anterior, will be the RVOT, or the RV outflow tract. So in RAO, I can see superior and inferior. I can see posterior and anterior, right? I cannot see right and left. I can just see superior or atrial, superior and posterior, which is the atrial, anterior and inferior, which is the ventricle, anterior, the RVOT, and posterior. So the posterior is the vertebral column side, the anterior is the opposite side. So right here, the CS os is posterior, and the His is anterior. Is this clear? So the data that we get from the RAO, where is the atrium? Where is the ventricle? Where is the annulus? What is anterior and what is posterior? That's the data that we get out from the RAO view. What about the LAO view? The LAO view is a short axis in the heart. Okay, where is the vertebral column? It's right here on the right. So this is an LAO view. How can I mark the left atrium? I do have the best signals, the best castor, which can help me, the CS castor. So this portion is the left atrium, okay? And this portion is the right atrium. And here is the septum, okay? So what do I get out from the LAO view? I get left and right, anterior and posterior. But I do not get atria or ventricle right here. I do not get an annulus. I don't know the longitudinal orientation. I just know the left and right orientation, the anterior and posterior orientation. So the CS os is right here between the left and right atrium at the posterior septal region, right? And then I go through the back side of the mitral annulus, on the left side of the mitral annulus, the posterior part of the mitral annulus. Where is the His? It's in the anterior septal portion, right? Where is the right atrium, high right atrium? Right here in the superior vena cava, down at the superior vena cava, or A junction. Why does it look like it is outside the margin of the right atrium? Because I do not see the longitudinal proportions, okay? Where is the RV? I cannot know that this is in the RV from the LAO. I know that we are in the RV from the intracardiac signals. I will know that I am sure in the RV from the RAO view. I need this to be clear before we proceed, please. If anybody has a problem, please let me know.
I have a question.
Sure, Joanne.
Yes, how about when the chambers are enlarged?
Again, I couldn't hear you.
How about when the cardiac chambers are enlarged? Like if the right atria is
Yes,
dilated or the
of
left
course.
atria, how do you define the
Of course.
anatomy?
You cannot tell for sure without intracardiac signals. That's why we do both at the same time. I mean, how do I know that I am on the annulus? Because in some patients with, like, for example, Epstein anomaly, they have a very huge right atrium and inferior displacement of the tricuspid valve. Okay? So, how do I know that this site is the annulus? By intracardiac signals. So we do not go blind, okay? We go both by anatomy and fluoroscopy and intracardiac signal. If the signal is giving me only A, so I'm still in the atrium. And I still proceed until I get down into the AV junction. So I get an A and a V at the site of the annulus. So in cases with very large left atrium or very large right atrium, we know this after we enter with the casters, and with the help of the intracardiac signals, we can draw our imagination about these cardiac chambers and the heart. Not all the hearts are normal, of course. We have lots of problems that we encounter inside, but we have no idea what are the borders except after we go in, we match both the fluoro and the intracardiac signals. Is it clear؟
Yes, thank you.
حد من الشباب عنده سؤال؟ روان، سامي، دكتور إلياس. Is this okay? It's clear؟
كله تمام.
كل
كله تمام يا دكتورة.
شكرا يا جماعة. دكتور أحمد جودة، في حاجة سؤال؟
كده تمام يا دكتور، شكرا.
اوكي، هنمسح بقى ده. دكتور أحمد جودة had a question a couple of days ago. How do we know where is the accessory pathway? Okay. During mapping. Let's talk about this for a little bit before we proceed. Again, Dr. Ahmed, see in the LEO, the description of the accessory pathways is based on the LEO view. Okay. So as we've mentioned, this is anterior, and this is posterior, this is left, and this is right, this is septal. Okay. The aorta is right here, in anterior and to the his. Okay. So if we need to localize the accessory pathway, okay, if we need to localize the accessory pathway, so this portion would be called left posterior. This portion, it's called left posterolateral, left lateral, left anterolateral, left anterior, left anteroseptal, anteroseptal, midseptal, posteroseptal, right posteroseptal, right posterior, right left lateral, right lateral, right anterior, and so on. So it's totally based on the LEO view. There are multiple nomenclature for the accessory pathways, but this is the one that we use in Egypt, يعني, according to the LEO pattern. Some people call these or paraseptal accessory pathways with different nomenclature, but the one that we use is the one that I told you. So if you get any case, like a real case that you are attending, we will write the report based on at which hour is the accessory pathway. We can say it is at 12 o'clock mitral annulus, 3 o'clock mitral annulus, 5 o'clock mitral annulus, okay? 5 o'clock tricuspid annulus, 1 o'clock tricuspid annulus, and so on. So it can be by clocks, or it can be by anteroposterior or lateral or whatsoever. Is it clear? Because you were asking me about the localization.
I have a question. When you're using the clock, is it like you're using one clock, or there is a clock for
Clocks.
for
clocks.
the 2 clocks? Okay, thank you.
Yes, a clock on the left and a clock on the right.
Okay.
And that's why we mention, is it tricuspid annulus or mitral annulus?
Okay.
Yeah. Okay, let's proceed. طيب The normal conduction sequence, in normal patients, first the earliest atrial signal would originate from the SA node at the high right atrial site. Where do we put the high right atrial signal? In the junction between the SVC and the right atrium. And how do we know that we are in the right position? SVC has no signals, okay, because it's not myocardium, it is a vein. So when we are in the SVC, the caster cannot see anything, it is blank, or it can see very far field atrial signals. As we go down, it starts to see atrial signals. So at the junction of the SVC and the right atrium, this is the site of the SA node. This caster we do not use routinely, but it's of very important significance in cases, for example, with Mahaim tachycardia, with accessory pathways, in cases with automatic sinus node tachycardia, reentrant tachycardias, and so on. But in real practice, we do not use it in all cases. So the normal conduction would start in the high right atrium, goes through interatrial or intraatrial conduction till reaching the His bundle. The His bundle, as we have mentioned, is at the annular site, right? We did say that the His at the AV nodal junction. So when I am standing at the AV nodal junction, I will see an atrial signal, an A. I will see a ventricular signal, a V, and I will see the His signal because I am standing right above the His. So the His signal, they have three data that it can give us. Where is the A, where is the H, and where is the V? And we can have an AH interval and an HV interval. Okay? And then after passing down to the His, it will go down through the conduction system to end in the right ventricular apex. Let's go back into the intracardiac EGMs. So if I am putting an high right atrial caster, it will see an atrial signal prior to the P wave on the surface ECG. Why? Because this atrial signal is the one that originated the P wave on the surface ECG. If I am standing anywhere inside the atrium away from the SA node, it will be after the onset or included in the P wave on the surface ECG. So any signal that is included inside the P wave on the surface ECG, we would be named A signal. Okay? So if I'm putting an atrial caster, it will read just one signal and it is named A. If I am putting a ventricular caster, it will read one signal, which is the ventricle, and it will be inside the QRS complex on the surface ECG. What about this signal? This is the AV node His bundle area, as we've mentioned, atrioventricular junction. So it will have an atrial component, a His component, and a ventricular component. And we need to know that the His deflection is a very short duration deflection. We have to see the AHV signal in order to make sure we are standing on the His. And then we can measure the intervals afterwards. So there is another type of signal that we can see is only an A and V if we are standing on any annular site at the annulus away from the His. So we'll only have an A and a V without a His. It would look just like the coronary sinus signal, like this and like this. Or the opposite according to exactly where I am standing. So I will only have an A and a V. Let's proceed. Type. That's the regular, basic intracardiac view of EGMs that we see in all of our cases. The first point, we need to learn how to read any strip or tracing that we are encountered with. And in order to make this easier for ourselves, we have to go systematic. The first point is to check the surface ECG. Everybody that teaches anyone coming inside electrophysiology, the surface ECG is the most important clue. If it is misconnected or misread, we will be lost inside the study. We have to prepare the case ourselves. We have to attach the ECG ourselves. We do not let nurses attach the ECG in the cath lab. The doctors always connect the ECG themselves, make sure where they are putting each electrode to make sure the reference points right here are correct and well connected. And just like we are seeing, this is a normal sinus rhythm with a P wave, QRS, and a T wave. Sometimes the P's are not this evident on the ECG, and we adjust the amplitude in order to make sure that we are seeing the signals. Everything of this has a huge importance, of course, but this is out of the scope of this lecture. Yani, we are just introducing how to set up the study and how to interpret the basic elements during the study. Type. And then we will have different casters, as we mentioned, at least 3 casters would be placed inside the heart. So we have to be systematic and go step by step. If I do not have the names on the left side of the screen, I still can determine exactly where my caster is. Based on what? Based on the shape of the signal and the timing of the signal. For example, in this first area, we have a single signal. So the single signal D could be an A, could be an V. Okay, how do I know what this signal is? By timing to the surface ECG. It is coming at the same time of the QRS, so this is V. What about the red one right here? It is a very small signal. This means I'm standing some way. This is a far field signal, so I'm standing more towards the SVC. This is not purely a high right atrial, and I am preceding the surface P, so I'm standing at the SA node or just above it. So this is an atrial signal. The yellow portion here would have 3 signals with a very sharp and short duration signal in the middle. So this is A at the same time of the P wave. This is an H, and this is a V at the same time of the QRS. Lastly, we have the decapolar caster, which can turn into 5 signals between each 2 electrodes. This signal is called A, and this signal is called V. And Dr. Ahmed was always asking, how do I know which is A, which is V? Especially during the tachycardia, things get so complex. So at first, we have to save a baseline intracardiac tracing for every patient. So I can tell how does each A look and how does each V look because they look different in every patient. According to the timing, I will know that this signal is a V, which looks like this. It is wideish and somehow prolonged, and the A signals are sharp. It's not the same in every patient, so we have to know what does it look like in each patient on each caster. Some labs start with the 9 and 10, and the 1 and 2 is down here. Some other labs, they do it in reverse. So you have to check it in order not to miss interpreting the EGMs. طيب I need someone بقى of you to try to tell me or go through this tracing and tell me what does each signal means.
Okay. We have ECG, lead 1, lead 2. We
Mhm.
have ablation catheter and the coronary sinus from 1 to 10 and his deflection or RV deflection.
Okay,
It looks like
the hiss only says hiss. ماشي? I mean what?
okay.
We don't care about the names. We need to know where the caster is placed
Yes,
because sometimes
yes,
we keep it named RV and we do change the site. We put it once in
yes.
the RV, once at the hiss, once in the right atrium. Okay, so we don't care about
Okay.
the name. We do
Then
care about the signal. That's
the side signals, yes.
exactly because we don't
Okay.
use the 4 caster technique. We use only 3
Mhm.
casters, and we sometimes start the study with only 2 casters and we just move them around. You do
Yes.
not stick to the names on this side. You see where the signal is and you just tell me where this signal is. Yalla, please let's
Okay.
go start.
Look sinus rhythm the earliest signal is A and the signal coincide with QRS is the V.
On which signal? On which caster?
Coronary sinus, for example, 1 and 2. The first signal A, the sharp
Okay.
signal, and the small signal V, which coincide with QRS complex.
Okay. Where is this ablation caster, Dr. Ahmed?
What? The ablation catheter.
Where is the ablation caster?
Where is the and the ventricle more ventricularized يعني small A large V.
Yes, there is still a small a, صح? There is still
Yes.
a small a, so I'm just
And
below the
and
annulus.
the annular lesion, the annular site.
I'm not annular, but I'm just below the annulus. I'm not in the apex. Okay?
Okay.
I'm not in the
Okay.
apex because I have a small a.
more ventricularized يعني.
Yes, it's at the annular side, but more ventricularized. What about the RV here?
The RV is coincide with the QRS signal.
Okay, I mean there is no
which means
far field A,
there is no A. There
right?
is no A.
There is no A, so I am purely ventricular. تمام?
Yes.
Where is the his caster?
I can't see his deflection. I can't see his deflection.
Exactly.
Only
We cannot see his deflection بالظبط. We can only see
an AV.
a
AV.
very small A, صح? A very small
Yes.
A and a large V. فthis
Yes.
this is more annular than the ablation caster.
Mm-hmm.
Okay,
More
so I can see more of an A, especially the proximal part here. The A is bigger than the his 1 and 2. His 1 and 2
annular.
looks somehow like the ablation caster right here. Okay, great.
The
طيب.
activation looks not normal. Sorry يعني they can في advice.
Mhm.
earliest signal looks in C1 2. The earliest activation. Is it eccentric activation?
We will need to draw a line in order to see it, but I'm not sure because the his deflection right here is the earliest ventricular activation. It's not 1 and 2.
Okay.
Okay, this depends. Let's put into consideration that sometimes the CS is not in the CS or not deeply inserted in the CS. تمام؟
In a good position.
Yes, in order to see if it's an eccentric pattern or concentric pattern, there has to be a his signal on the screen.
Okay.
ماشي. طيب, this is not very important if we are still starting, but this is the basic electrophysiological intervals that we need to do. If we are starting, we need to measure them in every patient in order just to get acquainted with it. Okay, the PA interval, the AH interval, and the HB interval. Why do we concentrate on those intervals? Because there are some maneuvers that will affect them if I am stuck with a tachycardia that I do not know how to diagnose. So a very short HV time means that this patient is pre-excited. Okay? The prolongation in the AH interval is critical in cases with jump and echo, such as the cases with EVNRT. So I only measure those intervals for the sake of the tachycardia. Of course, this is not the main indication. The regular intracardiac or electrophysiological study has to be complete by doing all those intervals. Okay, especially in cases with the bradycardia or conduction abnormality. Those intervals can tell us where is the block. Is it suprahisian block or it is infrahisian block? طيب, those are how to measure the intervals. يعني let's skip it for now. If you can بقى يا دكتور أحمد check this EGM. This is what we call eccentric pattern of activation. If we do see the his, it is late, and the CS1 and 2 is the earliest. This is totally apparent, okay, without thinking about it.
Also, the ECG looks pre-excited from the ECG.
Not very much. We cannot tell صراحة. We cannot tell. But of course, as long as we do have this intracardiac signal, this patient is currently conducting over the accessory pathway during sinus rhythm.
Yes.
Of course, he is pre-excited, or sometimes patients have local pre-excitation, and the surface ECG does not have a full manifest pre-excitation. That's why we do maneuvers or complete the study in order to see the manifest pre-excitation or the full pre-excitation. طيب, Joanne, you go through this tracing bit by bit and tell me where, which is A, which is V, where are those casters placed?
So on the survey CCG, one, okay, I can't see anything in 1, 2, and V1.
Okay.
I can see a small P and a V.
Yes.
And then there are no ablation catheters inserted yet. In the CS1, okay, in the coronary sinus one, I can see like almost fused signal. I can see the signal, the first signal probably representing the P, and then the QRS complex is just next to it.
It's not preceding the P, Dr. Joanne. لا.
It's
not
not
preceding.
inside the P.
Yes,
Like
it's
it is coinciding with the P on the survey ECG, and the
yes.
also QRS is just next to it, like it's almost coupled together. So
Okay, at
and
the CS1 and 2, there is what we
yeah,
call AV fusion.
yes,
Okay,
AV
AV
fusion, yes.
fusion at the side of the CS1 and 2. And then
And then
at
in
CS9 and 10, they are
9 and
distinct
10,
from
now
each
you can,
other.
yeah, separation, you can see A and V
Okay.
separate. So the earlier signal is like, okay, I can't say the earlier signal because the P, the A is almost in the same level in all the CS leads. But the QRS, the V is more further up away in the CS 9 and 10.
Okay, so just to make sure you understand this, whenever we are saying the pattern of activation is concentric or eccentric, we mean the next beat. I mean the next signal. So if we are during sinus rhythm, we do not care about the arrangement of the atrial signals. We do care about the orientation or the arrangement of the ventricular signals. And
Okay,
the
so
opposite applies if I am retrograde pacing through the ventricle. So I do say the retrograde conduction is concentric according to the A waves, and the retrograde is eccentric according to the A waves. So I want to make sure that you can understand this.
so I would like understand the terminology,
Mm-hmm.
eccentric and concentric, because I'm just used to antegrade and retrograde.
No,
So
look,
what is
antigrade,
eccentric? Mhm.
that's what we are going to talk about right now in a minute.
Mhm.
Antigrade means I am pacing from above, from the
Yes,
atrium.
yes, yes,
Retrograde means I am pacing from the ventricle.
yes.
The other nomenclature or terminology, concentric or eccentric, means I am going through the normal conduction pathway,
Okay.
A, H, then V, or
Mhm.
or I am activating the ventricle not through the His, and the ventricle right here at the CS1 and 2 is activated before the V on the His at the AV junction. This is where the normal AV nodal conduction would occur. So normally the
Mhm.
V at the His is the earliest V
Okay.
because this is where the conduction goes.
Okay.
But if I have a reversed pattern of activation, reversed mean the lateral area of the mitral annulus is activated prior to the septum and the His region. This is called eccentric pattern of activation. Like the laterality, it means laterality. It's
Okay.
not conducting through the septum. It is conducting elsewhere. This means I have an accessory pathway.
Okay.
Okay.
And concentric will mean?
Concentric will mean I am going down through the normal pathway. Concentric means I am going down through the His first, and then to the fascicles, and then through the bundles, and then through the ventricle.
Thank you.
So the left side of the ventricle would be the last area to be depolarized. Okay, the lateral mitral annulus would not ever be activated earlier than the septal portion of the ventricle.
Thank you.
CS9 and 10 is seeing the septal part. CS1 and 2 and 3 and 4 are seeing the lateral part. So whenever 3 and 4, 1 and 2 precede 9 and 10, this is an eccentric pattern of activation.
Thank you.
Okay. So right now we are going to start how do we go through any case of electrophysiological study, either looking for normal conduction or not, or tachycardia induction or not. The first thing, as we've mentioned, the basic intervals, just to make sure everything is normal, especially if we are going to ablate AVNRT or an accessory pathway which is paraseptal or parahesian accessory pathway. Medical legal purposes, we have to know the normal intervals of this patient. This patient was coming inside with a normal PR interval, normal AH interval, normal HV interval, and I caused him right bundle block. I caused him AV nodal block. I caused him first degree heart block. Okay? But if the patient has underlying conduction disease from the beginning, I would know that this is the normal interval for him, which is prolonged, and we came out with the same level of conduction abnormality. This is for medical legal purposes, especially in patients with parahesian or AV nodal area ablation. The second point we comment on, as we have talked about, is it a one-to-one relationship? Like, is it normal, regular sinus conduction with one-to-one activation? And is the pattern of activation going through the His bundle first and then the ventricles, or it's going through the ventricles first by passing the His through an accessory pathway? And we will start our study بقى right now. First, we do retrograde pacing first, بس يعني let's talk about this. We will go for antegrade burst pacing. Antegrade burst pacing means I will give stim, 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 a train of stimulation. It's called burst. Burst means tick, 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 tick. Okay? It's burst. I will look at specific questions to be answered. Did the surface ECG change or not? When would the surface ECG change during antegrade pacing? أحمد سامي ممكن تقول لي لو سمحت؟ أحمد سامي طلع. روان.
ممكن بس حضرتك تعيدي السؤال تاني؟
لما أنا أعمل antegrade pacing
امم
I am looking at the surface ECG,
امم
what is an expected change in the surface ECG during antegrade pacing?
ان يحصل وينكي باخ يعني؟
ممكن، بس مش السيرفس هو اللي هيقول لي الوينك باخ، يعني I do have intracardiac
في الAGM
signals.
نفسه.
ثانية يا دكتور أحمد سيبها تفكر.
لو في حد كتب انا هتلقى مساعدات عادي. ثانية.
مفيش أي فكرة تانية في دماغك ممكن السيرفس ECG يتغير لما أعمل antegrade pacing؟
احنا بنتكلم على يعني AVNRT ولا AVRT
لا
ولا
أنا
اي حاجة؟
بتكلم عموما، ما قلتش
اه
AVNRT. لا in general if I give an atrial stimulus should the surface ECG
Can you
change؟
speak in English, Rawan? And
اوكي يا دكتور
Rana?
ماشي، حاضر يا دكتور.
Because Juan is listening
هم،
and this is عيب يعني.
حاضر.
استني اتفضل.
فروان if I
ايوه
give an
فهميكي.
antegrade pacing should the surface ECG change or not in normal individuals؟
يعني
The morphology of
there may be
the
induction of tachycardia مثلا يعني.
No, before induction of tachycardia, during normal conduction. طب دكتور أحمد.
You mean the morphology of QRS compared to
Yes, I
retrograde
mean the
conduction?
morphology of the surface ECG. Yes.
The morphology usually not changes.
The morphology is
Like a
normally
sinus.
not changed.
But
It's normally not changed. Right. In
yes.
what case would it change?
Compared to retrograde conduction, if you have accessory pathway.
During antegrade conduction.
If the conduction antegrade going through the accessory pathway.
Exactly.
It will,
so if the patient, yes, if the patient was not fully pre-excited or was minimally pre-excited on surface ECG, and I do antegrade burst pacing, sometimes the antegrade conduction across the AV node stops and the conduction resumes across the accessory pathway. So the surface ECG changes into a pre-excited morphology.
Yes.
That's why we said we do a high right atrial or lateral tricuspid annulus burst pacing in cases of suspected Mahaim, for example, accessory pathway. So during burst pacing, the antegrade conduction should not change in normal cases. If it does change, this means that I am conducting over something other than the AV node. Okay? Is it clear?
Yes.
Okay. What else could happen, Dr. Ahmed? We just discussed this like a couple of minutes ago. Could the surface ECG change for any other reason other than the accessory pathway?
If we have intermittent bundle branch block, rate dependent.
ممكن if I do have a bundle block, or if I am miscapturing the ventricle, I am capturing the ventricle instead, as we've mentioned.
Yes, if I have a
Okay.
retrograde conduction
No,
or
I mean,
antigrade.
yes, it would be like retrograde, but I am not meaning retrograde. I am pacing from the CS, but it is capturing the
Yes,
ventricle. Okay.
and a branch like yes, yes.
Yes. Okay, so I have to look at the surface ECG. Is there any change? Of course, the Wenckebach is a correct answer. Dr. Ruwen, تمام. The manifest pre-excitation is a correct answer, or miscapturing the ventricle from a branch in the CS. Okay. The second question that I need to answer, the AV relationship. Is it again a one-to-one conduction, or when I do start to Wenckebach بقى? Okay, 2-to-1 conduction or a non-conducted ventricular, the atria does not conduct to the ventricle. The third question is about the decrementality. The normal AV nodal conduction is decremental. So when I do increase the rate of the pacing, the AV interval or the AH interval will prolong. Normally, in any patient with intact AV nodal conduction, the faster the heart rate or the faster the pacing cycle length, the shorter يعني the pacing cycle length, the AH interval will prolong. Okay, this makes sure that this antegrade conduction not 100% يعني, but most of the cases for starters يعني decremental properties is AV nodal conduction. And then Wenckebach cycle length, whenever the antegrade conduction leads to Wenckebach, that's the number that I need to state. This is the Wenckebach cycle length through the antegrade conduction. After I do the burst pacing, I do something called antegrade extra stimulus pacing. Extra stimulus means a PEC. So now I will give a PEC. This PEC can do multiple things. The first thing will show us the decrementality again. It will augment the comment on the decrementality because it is of a shorter cycle length, same as we have mentioned with the burst pacing. The second thing, the pattern of activation can change. I mean, if the train is coming down the AV node, and then I do give a PEC while the AV node is refractory, it can conduct through what?
Accessory maybe.
Accessory pathway. So if I do have ECG change during the PEC or intracardiac signal change during the PEC, this could mean the AV node is blocked right now and the conduction is through the accessory pathway. So each PEC I am giving, I am looking at the surface ECG, at the AH interval, at the pattern of activation of the ventricular beats. Is it the same or it does change with the PECs? Okay. Sometimes there is an AH jump. We will see it in the tracings right now. And whenever there is an AH jump, this is known as effective refractory period of the fast pathway. So the fast pathway was conducting until it was blocked. So the conduction changed from the fast to the slow, which is described as AH jump. Okay, this is the effective refractory period of the fast pathway. If we only have fast, I mean the fast pathway was conducting well and then there is no slow, so it will Wenckebach. It's the same as Wenckebach. It will not conduct, but it is called the refractory period because it is an PEC or extra stimulus. But if we do have an AH jump, it will be called effective refractory period of the fast pathway. And when the slow pathway still decrements and then fail to conduct, it will be known as effective refractory period of the slow pathway. We will see tracings بقى for this. طيب, the next step is retrograde burst pacing. Actually, in clinical practice, we do the retrograde first. But I am just stating what we need to concentrate upon whenever I am doing each maneuver. Because we do it real quick in the EP lab, just because we are used to it. But you have to revise every study and see what did happen with the retrograde pacing. Was there a one-to-one conduction? Was the pattern of activation the same? Was there a change in the surface ECG, what was the decrementality, positive or not? What is the Wenckebach cycle length? So we do comment on the same items that we commented on the antegrade pacing. But this time we are conducting the retrograde properties of the heart. Again, if I am pacing from the RV, Dr. Ahmed, what is the morphology of the QRS complex on the surface ECG?
It will be wider QRS complex. Spike followed by FA capture. Spike followed by wide QRS.
A spike followed by a wide QRS. Okay. If I am pacing from the RV apex, what is the axis of the ECG? V1 would be positive or
the axis will be negative.
great.
V hat
V1
yes.
V1 would be negative. تمام. The inferior leads would be negative or positive.
Negative.
The axis will be changes. The retrograde. The inferior
Yes,
lead
it will be. I don't mean the intracardiac. I'm talking about the surface ECG.
Yes,
so we
yes.
said
I
the
also
V1 would be negative. The inferior
yes.
leads would be negative or positive.
If
I'm facing from the RV apex,
inferior lead,
the inferior lead
it will be the axis. There will be negative, I think.
will be negative because I am facing from the apex. Okay, the inferior lead would be negative. Okay, type if I am pacing from the RV OT, the RV outflow tract, V1 will be
V1 will be negative.
V1 will be negative. That's correct. The inferior leads, Dr. Joanne.
Inferior leads will be positive.
Yes. So right or left, V1 negative or positive. Apex or base according to the inferior leads. Okay, this is agreed. If we are pacing from the left ventricle, the V1 would be?
From the left ventricle, the V1 will be positive because it will give a right bundle.
A right bundle branch morphology.
Morphology, yes.
Exactly. Okay. So I can know where the caster is. Is it in the apex? Is it in the base? Why are we talking about this? For later on purposes, we will do what is known as differential RV pacing. I will pace sometimes at the apex. I will pace sometimes at the base. I will not know where I am pacing from the fluoro because I don't have the fluoro on still images after the study. But I can tell.
Please معلش دكتورة ممكن تعوديها. Can you repeat يعني?
Okay, there is a maneuver known as differential RV pacing. This is one of the maneuvers that help us in differentiating between, for example, septal accessory pathways or accessory pathways. In order to know where I am pacing from the ECG only, without seeing the fluoro, because on the fluoro I will know if I am at the RVOT or I am in the RV apex. But if I don't have fluoro images, I will check the surface ECG. If it's negative in V1 and negative in the inferior leads, so I am in the RV apex. If I am negative in V1 and positive in the inferior leads, so I am in the RV base or the RVOT, the outflow tract.
Yes.
Okay.
The other, if we in left ventricle, we have
it will be a right bundle morphology. V1 will be positive.
A right bundle morphology, yes.
Okay. Okay. So let's go for tracings. Joanne, I'm writing the answer right here, but try to skip it and just go with the signals on the intracardiac signals. Where is this caster, Joanne? The RV distal caster. Where is it? Where is it placed? Joanne?
I'm looking at it, just a minute. I'm looking at the survey
okay, take your time. Okay, I'm waiting.
Looking at the survey ECG, and this is the QRS and the P. So this caster is looking, so the QRS complex, which is the R, The V is earlier than the A.
Earlier from which point of view?
No, sorry. So it is, I can see an A and a B. Please, one. I can see an A and a V, and the A is is pronounced in this caster. So I think it is in the annulus, around the annulus.
Okay. Yes. So this RV is not in the RV. This RV caster is not in the RV because we can see atrial signals on it. That's why I told you we don't care about what's the caster called. We do care about the intracardiac
Make the
signal.
seatbelt.
Hey, doctor? Okay, so the RV caster is not purely in the RV apex. It still can see atrial signals. It is close to the annulus. Okay? Type. What is going on here? First, that's what we need to know. We are pacing. How do we know we are pacing? This pacing artifact that is seen on S5 and 6, for example. So I do have a spike. I do have a spike. I do have a spike. I do have a spike.
Yes.
If I do go up there to see the surface ECG, this is the pacing artifact, this is the P wave, this is the QRS complex. So this is the A wave.
Make your seatbelt.
I couldn't hear you, Joanne.
Sorry. There was a phone call. Sorry.
It's
If you
okay.
can come again.
Okay, so right now I see that I am pacing from the CS5 and 6 caster. Why I am saying this? Because this is the pacing artifact seen on this channel. And this is pacing interval. This is 400 milliseconds, 390, 370. So this is a burst pacing. I need to know right now where is the A and where is the V. So if I go up the spike to the surface, this is the spike on the surface ECG. This is the P. So this pacing is capturing the atrium. Okay? And then we have the V. Okay? This is the QRS complex. So those are the V. This is the A. Those are the V, and this is the A. Okay? Now we do track with our eyes where are the A's and where are the V's. Again, the cycle length right here is 400. The cycle length right here is 370. By your eyes, without measuring, can you see the first beat and the last beat? The first beat,
Yes,
this is
I can see.
and this is the V. Yes, it's longer. Okay, so the first beat at 400 milliseconds, the AV time, yes, it's shorter than the AV time on the 370 cycle length. This means that this conduction is decremental. Okay, so there is a progressive prolongation in the A, supposedly H time, it should be at the H, okay? AH or AV time is getting longer with faster pacing cycles, okay? And we can appreciate this by our naked eyes. And the second question, what is the pattern of activation? Is the CS proximal earlier or the CS distal earlier?
CS distal
proximal. From the V. Yes, proximal.
Is earlier, okay? Still, this tracing is not complete. We should see a His signal, and the V on the His should be the earliest. Let's be agreed on this. We have to see an H during antegrade pacing. This is not a correct tracing. Let's see another tracing from the Ehab. Okay, again, surface, ECG, high right atrial. How do we know this is high right atrial? A single signal coinciding with P wave, coinciding with the P wave. Then we have a caster here with 3 signals on it. 1, 2, 3. 1, 2, 3. Okay? So this is his signal.
Antegrade pacing from high.
Okay, Dr. Ahmed, I am just trying to be systematic in order for you to feel it easy with time. But
Okay.
we are not just
Okay.
looking
Okay.
at what we are talking about, we are looking at the whole tracing at the same time. Before interpreting what's going on, we need to make sure we understand where we are, where are the signals, where are the casters, and then we will go on to what is going on through the maneuvers and whatsoever. So this is sinus. Yes, it is sinus. Where is this caster? It's high right atrium. Where is this caster? It's his. Okay. Where is this caster? In the CS. Where is this caster? It's in the RV. So I do now know where is the A, where is the V, and where is the H. And then, as you have mentioned, this is antigrade pacing. How do I know this is antigrade pacing? Joanne, how do I know this is antigrade pacing?
Because first of all, I can see the pacing is high right atrial. The spike is in the high
Yes,
right atrial.
the spike is at the high right atrial, exactly.
And then the earlier signal is in the his, the in 9 and 10. This is
Okay.
that is for
Distal.
that is for the P. For the ventricular, it is in the CS 1 and 2.
Okay.
Yes.
Joanne, again, I do not care the atrial activation. I do not care about the atrial arrangement. I do care about the ventricular conduction. So when I am considering which is the earliest, I would look at those signals, the V's. Okay? So this V at the his caster is the earliest at the distal. Okay, this V signal. Those are later. Okay? I do not care about this pattern of activation. I'm not looking at the atrial signals. I am looking at the ventricular conduction.
So I have a question, because when you look at the CS1 and 2, that
Mm-hmm.
QRS complex, it's looking to me like it's earlier, unless to my naked eye.
It's not earlier than the his.
Okay.
Okay? You can see the his?
I'm seeing a like
I
a
will
like AHV.
yes,
So
and
now in that,
this is
so I
the start of the V signal at the his. This is the H,
okay,
and this
okay,
is the V. This is the
I-
distal his, and this is the proximal his. The distal his is slightly inside the ventricle more because there is no A on this caster. The
okay,
A here. Okay.
okay.
Let's look at something different. Let's look at the AH interval. This is A, this is H, and this is V. This is A, this is H, and this is V. This AH interval is longer than this one by the naked eye, right?
Yes,
Look at the next one. It is longer than the previous one, right?
yes,
So this AH time is prolonging. That's correct. So when I am pacing antigrade, the AH time is prolonging until one of the P's did not conduct. What is this called? This is called Wenckebach cycle length. Antigrade Wenckebach cycle length. So this P was not conducted. This is the same as mopeds type 1. I have a PR interval, a prolonged PR interval, a much more longer PR interval, and then blocked. Same as the surface ECG. So if I am increasing the rate, I will have an AH prolongation and then a blocked A. It will not conduct to the ventricles. This is known as antigrade Wenckebach cycle length.
وسؤال معلش دكتور هذا question يعني when Quebec cyclinic mean the fast pathway reach the refractory period صح؟ Is it?
We do not say this when I am burst pacing. This is burst and not extra stim. I am talking about fast and slow. I can tell fast and slow from the burst, but not on your level. فlet's be
Yeah.
systematic بس to start يعني. I will comment on the fast and the slow during extra stimulus spacing. تمام. And we will get examples for this. But at least during burst spacing, there is prolongation in the AH interval until it was blocked. So this is called Wenck-Bach cycle length of the antegrade conduction limb. Okay.
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 Type. Let's continue. Another tracing. The ventricular pacing, it's the same. برضو let's say this. The spike is coming from the RV signals, the RV caster. And to make sure this is RV capture, we will look at the surface ECG. So V1 here is wide and negative, right? So I am capturing from the RV. This signal, the wide signal to start, is the V signal. And this signal is the A signal. How do I know this? From knowing the baseline of the patient before retrograde pacing is the same patient as this. So how does his A's look like? They look sharp, while his V's look wide like this. Okay, same patient. I'm coming to this. Of course, this is the A, and those are the V's. Okay, those are coinciding with the QRS complex. Those are coinciding with the retrograde atrial conduction. طيب, if I need to say, is it concentric or eccentric? Can someone go through this with me?
It looks concentric because the distal is late.
Which signal is late, Dr. Ahmed? Do you have a marker on your phone? Can you show me which
No.
signal?
CSD after ablation catheter.
D?
Yes.
This signal?
Looks late.
Okay. So anybody else has a comment on this? Joanne?
Okay, so you're facing from the RV.
Mm-hmm.
So we expect it's going to be coming backwards to the, so it's retrograde pacing.
Okay.
Which when I look at the QRS, the V. So the V is earliest in C in the I believe it will be 9 and 10. Yeah, so I think it's right in what is describing that this is late, but I don't know if you can apply the concentric and eccentric when you are retrograde.
Yes, we do apply the concentric and eccentric during the retrograde, but what I need you to make sure, because Dr. Ahmed said this signal is late, we do not comment on this signal, Dr. Ahmed and Dr. Joanne. We do not care about the ventricular activation arrangement. We do care about this signal, the atrial activation.
Okay.
Okay? This is a very common mistake that you keep doing. Again, we said, if I am antigradely conducting, I'm commenting on the ventricular pattern of activation.
Okay.
If I am retrogradely conducting, I am commenting on the atrial pattern of activation.
Understood.
Yes, the CS proximal is the earliest, but I'm not talking about
there
this.
is a fusion.
Okay.
I'm talking about this.
The difficulty because there is a fusion between A and V's.
I cannot say this. I cannot say this during retrograde conduction. We do not assess the VA retrograde VA time, especially to start. In the start, we will wait for shorter cycle lengths and the decrementality to comment. Okay, it's not the same as during sinus. They are fused or not fused. It doesn't work this way on the retrograde conduction. We will wait on the decrementality during the burst pacing. But what I need to comment upon, yes, this is retrogradely conducting at the CS proximal first, but because the A wave is earliest and not this signal is the earliest. Okay.
Okay.
طيب, the same patient, but I did increase the pacing rate and I did shorten the cycle length. And now we can see the difference between the V waves and the A waves, the V's and the A's. Okay, this means that this patient has a decremental conduction, right? This is the same patient. So this was the VA time. When I did make the pacing cycle length faster, the VA time was increased. So this
Yes.
patient has decremental conduction. And now we can see the A purely in a concentric pattern of activation, right?
Yeah.
So the CS proximal right here is the earliest. So now I can make
Yeah.
sure this is decremental and concentric. In this view, I can only say it is concentric, but I cannot comment on the concentric except after making the cycle length shorter, because sometimes when the AV node blocks the conduction, the same as the antigrade, when the AV node blocks, it can retrogradely conduct through the accessory pathway. So I have to continue making the cycle length shorter and shorter until the Wenckebach cycle length. At this time, I can make sure there is no retrograde conduction across any other area other than the AV node. تمام? Is it clear so far? طيب, this in this بقى tracing, this a VA, a VA, a V without an A. That's when we say what بقى? That's when we say this is Wenckebach retrograde Wenckebach cycle length. Okay? So there was decrementality in a concentric with a Wenckebach cycle length at 380 millisecond, for example, in this patient. Okay? Is it clear so far?
The cycle length meaning the measurement from the last V to V or the
Yes, the spike to spike. Spike to spike.
spike to spike. The last spike to spike. Yeah, the last two spike.
Yes, I mean at this cycle length, 200, for example, what we can see here, 230, the patient is conducting. 230, the patient blocked. There is a problem with the 150 thing. There is a wrong marker or something. But we measure this RR interval, and the RR interval that blocks would be called the Wenckebach cycle length, either antigrade or retrograde.
380.
Yes,
When
because I
measured.
can see it right here in the top of the screen. It's a burst pacing at 380. S1 is 380. The markers are mismatched right here.
Yes.
Okay.
Yes.
طيب, this is another tracing. برضو Joanne, if you can tell me what we can see before we jump into conclusions. Please go bit by bit through the ECG, the signals, and so on.
So the service ECG,
Mm-hmm.
the QRS complex is looking wide.
Yes, it's very wide.
It's very wide. I can't see the P very well.
Yes, we cannot see the P's.
Yes, but I can see it is where it is coinciding in the V in the I right atrial and his catheters and also the CS. So CS1 and 2 looks like the signals are late. Compared to in the one in high atrial sorry, it's just
look, I will tell you something. First
high
of all,
right atrial.
neglect the high right atrial for now, because we will know the answer for it in a little bit. If we can look at the CS caster.
Yeah, so the CS casters, it's late in the CS1 and 2, but earlier in CS 7 and 8, which is very visible, and also in the HIS.
In the HIS,
yeah.
Yes. Okay.
2 to 1 block.
So
no, it's not 2 to 1 block.
I'm looking at another signal.
Wait
I'm
for a
looking at
minute.
another signal. It's like the A is coming after the V.
in this signal?
Yes, I'm assuming because I can see in the high rate atrial, that is where it seems to be coinciding.
Yes.
They are very
So
tall.
this is the V. That's what you mean.
Yes.
The
So
first thing we need to know which is the V and which is the A, and then we
Yes.
will know what's going on.
Okay.
Right,
So
Joanne?
yes,
Those
so
are the V's, right? The one
yes,
that I am saying. Those
yes,
are the A's.
there is, yes,
Huh? Okay.
yes.
Are
So those are the V's still,
okay. Those are
the A's.
and those are the V's. خلاص. Okay.
Yes.
So we know what
Yes.
does the V look like? What does the A look like?
Yes.
Type. And the RV or the stimulation here, I am pacing from
You're pacing from right
Mhm.
ventricle. That's why the V1 is negative.
Yes.
Yes, you're pacing from the right ventricle.
Apex or base?
It's in the apex.
It's in the apex because the inferior leads are negative.
Yes.
So I am pacing from the RV. Is it capturing the ventricle?
Yes, it is.
Yes, it is capturing the ventricle. So the spike to spike, it is capturing the surface ECG. The V
Yes.
to V interval is matching with the spike to spike on the pacing.
Yes, except
stimulation.
one. Oh, yes, yes. It's matching with all of them.
So the V's are captured, okay, and paced.
Yes.
What about the A's?
So in the first spike, the A's are there, are captured.
Okay.
In the next lead, you don't see, you see only the V spike,
Okay.
but the A comes back quite late.
Are those A's related to those V's?
So now, because this is intracardiac, I'm trying to think of the.
Type.
They
Think
don't
about
seem
it.
related, but it's
Yes, they
possible.
don't seem related. That's the
Yes.
clue. Think of this as a surface ECG, Joanne and Dr. Ahmed.
Okay, not related.
The V
Yes,
to V
have to
interval
be
is fixed, the A to A interval is fixed, and both
complete
of them
have to
are
block.
not related to each other, right?
Complete have
Yes.
to block AV dissociation.
This is AV dissociation or VA dissociation in this scenario.
Okay.
But this means that I am capturing the ventricle, but nothing is coming back to the atrium by pacing. The A's are totally dissociated.
Okay.
Okay? So
Yes.
I have P waves that are totally not related to the ventricular beats. This means I have no retrograde conduction from the ventricle to the atria, not through the AV node and not through any accessory pathway. This is a very good sign if there was retrograde conduction at the start of the study and I do ablate the accessory pathway and then I do not have retrograde conduction anymore. This is a very good sign that this accessory pathway was successfully ablated. Okay? Because there is no other way that the conduction could go back because it was going back through the accessory pathway and now it's not going back through anything. Normal people can have retrograde conduction through the AV node. Other normal people can have retrograde ventricular dissociation, VA dissociation. If it is present from the start, this is a good sign that we do not have an accessory pathway. Of course, we need to give atropine and make sure that
slow or slow pathway or accessory pathway.
لا slow pathway has nothing to do with this خالص. I mean accessory pathway.
We don't have accessory pathway.
Yes,
Okay.
slow pathway has nothing to do with this sign. Retrograde VA dissociation means I am not going back through anything, not the AV node and not the accessory pathway.
Okay.
Dr. Ahmed, you
بس
did
ملهاش
attend the last case that we had after ablation of the accessory pathway. We did give adenosine, right?
Yes, there is a
Why
block.
do we give adenosine? To block the AV node.
To block the AV node, yes.
And I do retrograde pacing at the same time. If there is dissociation, this means AV node is blocked and there is no other way for the signal to come back to the atrium. This is a sure sign that the accessory pathway is ablated.
Yes, يعني معناها العلامة الفي ديسوسيشن نستخدموها للاكسسوري باثوي مالهاش علاقة بالسلو باثوي.
Yes, it has nothing to do with the AV RT or the slow pathway.
Yes. Okay.
Joanne, is it clear? You are doing great today.
It's because I'm relaxed away from home and not here.
Okay. Things don't go this slow in the EP lab. We have to be like real quick, but you have to take it slow at home and then do it very fast in the CAS lab. Okay. So what we have talked about so far was the antegrade and retrograde per spacing. The next portion would be the extra stimulation pacing. I would give S1 and I would give S2. If you are tired or you're totally not, it's been a long time. I just didn't see that we have been for a very long time. I think we can stop for now and continue
Yes.
another time.
Another session, please.
Yes, I'm so
Yes.
sorry I didn't check the time.